All
Welcome
right.
back to another episode of the Rick and Danny Show. Danny, how you doing this today?
Doing great, Rick. I had a nice spring break with the family. You and I got to play some golf. It was a lot of fun.
Yeah, that was a lot of fun. You had a good trip and everyone had a good time, huh?
Yeah, Rick and I were in Orlando for a little bit, and we got some time to ourselves,
Majestic
which is,
Orlando.
yeah, it's majestic. Played one of the Disney courses, which was nice, and then to two of the other courses close by. So it was a nice weekend.
Is that why he's in such a good mood this week?
Yeah, I think Rick's in a better mood. I'm a little more relaxed, although getting back to work after a break is always tough, but it's good. We feel good. We played, I think you had one good round of golf, right, Rick? I had a few good rounds, but you had at least one.
Dang. Yeah, well, glad to be back
Savage.
and yeah, usually it's Brenna kicking me to the curb, but today
There
it's
goes
Danny.
his good mood. Thanks, Danny.
All right, Danny, I see how it is. Great, great. Yeah, no, Danny's playing great. It was so much fun to watch and I enjoyed every second of it. A lot of fun coming in and out.
I love playing. I love playing with you, the boys. We had a good time.
Yeah, it was a good time. Thank you.
That was really savage, Danny.
I'm sorry. He really okay. He really only had one bad round. That's it. One bad round.
Yeah, I had one good round, one average round, and then not a good round.
Okay.
A round of the shakes.
One good.
All right.
All right.
We're
Well,
we're off. We're off. What
good.
So
I
what are we going to talk about today, Danny, Mr. Expert level Rory McIlroy level golfer? You please you pick the topics because
well,
clearly I just get to bask in your glory on a daily
what I hear
basis.
from our listeners is that we need to talk a little bit more about medicine and what we do. So Brenna had some good ideas, and I feel like we have some good topics today. One of them being imaging, and you and I both utilize our imaging quite a bit for our patients, and then theranostics, which is another great topic that I think, Rick, you can explain better than me. So I think we're going to start out talking about some of the imaging capabilities we have at CSNF.
Yeah, I think you know, cancer care really it's so dependent on imaging. For many cancers, we can't follow progress with blood work. We can't follow progress with, other tests. A lot of times, imaging is the primary means in which we kind of determine whether someone's treatment is working, whether someone's treatment's not working, giving them good news, bad news, and everything in between. So having imaging integrated in our practice has been a blessing. And I think the patients really enjoy the seamless experience of knowing that their doctors are taking part of their imaging process. The people reading their scans are, focused specifically looking at cancer. And kind of the whole fact that it's under one roof, I think really makes for a good experience.
Completely agree. And I think one of the things that sets us apart is having the capability of imaging at a majority of our centers. Even though we don't have units that are permanent at all of our centers, we do have mobile units that come around. At our beaches office, for example, and where Rick, you work at South Point and Fleming Island, we have a mobile unit that does CT imaging, that's computed tomography, and then PET CT imaging as well, correct?
Yeah, that's correct. And then here in a few months, we'll hopefully have a fixed MRI unit as well as a fixed PET unit here at South Point. So we'll be able to have those available and then still have our PET CT and MRIs that go to many of our offices to really, especially how spread out Jacksonville is and Northeast Florida is, being able to give patients the appropriate scans they need without having them drive across the country to get them is, I think, a value add for our patients.
Yeah, and I think we utilize the CT imaging and the PET CT imaging for most of our cancers that we treat at CSNF. We use it for staging purposes. We use it during treatment to assess responses, and then we utilize not as much PET-CT in the surveillance phase, but we do a little bit of PET-CT and mostly CT imaging post-treatment to hopefully, if we're catching cancer early, that we're verifying that the cancer is not returning and that it remains in remission.
No,
Um,
exactly. And I think the other piece where imaging plays a role is research, on clinical trials. There's specific protocols each trial will have to look at a response. There's standardization of, when we say someone's tumor is shrinking, are we saying it's not just a guessing game. There's some specific criteria depending on the situation. So yeah, it really is. I mean, you can't really practice or do oncology in 2025 without imaging.
yeah. And I get a question a lot about, why aren't you getting a PET scan all the time? Why, do you order a PET scan sometimes, a CT scan other times? And, when we do a PET scan, we do a CT scan overlay and merge the images together to, evaluate the whole body. But the diagnostic quality of the CT scan when we do a PET scan is not of the same quality as a CT scan, which is diagnostic, which is usually what's used for staging purposes in a lot of cancers. Actually, I mean, historically, CT imaging was done primarily for staging workup, but now we're incorporating PET-CT more. And one of the things I tell patients, if we really want to look at a lot of detailed structures, bone, soft tissues, etc., we're either using a diagnostic CT or an MRI or both, not a PET-CT scan. Do you
Yeah, I
tell
think,
patients that?
yeah, I mean, I think that what you said is generally, very true. There are protocols where you can do diagnostic CTs at the same time as the PET scan. But yes, in general, it's kind of two separate purposes and why you're ordering them. The way I explain it is very similar to you. A PET scan kind of gives you the rough overview of the land and kind of gives us areas where maybe we want to focus a little bit more if we see something of concern. And then getting a diagnostic CT or a diagnostic MRI really provides the anatomical information on, size of things, what's their relationship to muscles, nerves, blood vessels, things like that. So yeah, I think they work together, but yeah, in general, a PET scan for most cancers is not used in the surveillance setting because it doesn't really add a whole lot of information and costs the patient more money. So, it's a financial aspect of it as well. If it doesn't add anything, why would you make somebody pay
Right.
for it? So I think there's that aspect of it too.
And PET-CT scans are exposing patients to more radiation over time, especially if you're ordering them often.
Yeah,
And
exactly.
yeah, compared to a CT. But PET CTs, definitely have a lot of advantages because nowadays we can use different radio tracers that are useful in different types of cancer. The one that we use most commonly is FDG, fluorodeoxyglucose, and we use that for like lung cancer staging and workup. Could you tell the audience a little bit about the different radio tracers that we use nowadays?
Yeah, so there's several available. Like you said, most common is FDG, which is basically, as I describe it, radioactive sugar. And that's used for a variety of cancers, lung cancer, melanomas, a whole bunch of other, it's the most commonly ordered PET scan. For prostate cancer, we have PSMA linked radio tracers that are specific in most cases for prostate cancer. In breast cancer, there's Siriana scans, which is linked to estrogen receptor products. So that would be something useful for hormone receptor positive breast cancer. In certain neuroendocrine tumors and meningiomas, there's dotatate, which is another radio tracer that's specific in general for those types of tumors. Those would be, I would say, the four most common radio tracers we use these days, but the interesting thing, and it'll tie in a little bit to some of the research we've talked about in the past, is there's a lot of research being done and companies looking into different radio tracers for different cancers. So I think it's really, we're still on the early cutting edge, if you will, of radio tracers that are going to be specific for tumors. And we'll talk about a little bit more next episode when we talk about theranostics. But these specific diagnostic radio tracers are also the backbone for the therapeutic end of treatment as well in some diseases. So I think we're going to be, it's definitely a rapidly evolving frontier of
hmm
cancer care.
Yeah, because it's the PET imaging is going to emit or fluoresce in areas where that radio tracer binds to or is taken up by the cell, right? And so you're going to get this level of metabolic activity or activity based on the binding of whatever radio tracer it is, correct?
Yeah, so it gives you at least a rough idea that if something lights up with a specific radio tracer and you have a therapeutic agent that targets that same target, the thought process is it will obviously hit those areas that we see on the scans.
And then MRI, we touched on MRI imaging. MRI does not expose patients to radiation, uses a big machine, big magnet, gives really high quality imaging of the soft tissues, bone. We use it a lot in terms of staging workup and, to determine staging for prostate cancer, rectal cancer. We don't use it a lot for lung cancer, but, GI cancers. MRI, it's a longer exam to get through for patients, usually depending on the type of MRI, anywhere 20, 45 minutes of time. But what I think we should tell patients is it really provides some of the highest quality of imaging that we can do for soft tissue and to evaluate how a particular cancer is invading into other structures.
Yeah, and MRI, so you kind of touched on it, but magnetic resonance imaging, that basically uses magnets that essentially flips, molecules in your body, the polarity of the molecules, and then as the time it takes for that to go back to normal, that's all measured and then calculated out, and that gives you different signal gradients and things, and that's what makes up the image in aggregate. But yeah, it's really, really, I mean, on the radiation oncology side, it's probably, we order a lot of those scans because for us it's extremely important when we're talking about things like brain tumors and other lesions where, we're talking some spots of cancer we treat are only 1 or 2 millimeters in size. And a CT scan, even your best CT scan, will not be as sensitive at picking up areas like that. And the MRI will. So it's an extremely important tool when it comes to both diagnosis and therapy on the radiation side. And as you mentioned, Danny, a lot of cancers, to get really appropriate staging, you need MRIs. You mentioned rectal cancer, prostate cancer, several GI cancers. An MRI is going to be a better test to really give us a sense of how advanced do we think the tumor is, and that plays a critical role in terms of what treatments are recommended. Does a patient need to go to surgery first? Should they have other treatments first, then go to surgery? Is surgery completely off the table? So, these scans are just, I mean, again, you can't really do appropriate cancer care without them. So at CSNF, being able to have kind of all three tools in the toolbox, I think is very helpful, just to provide that really integrated care, and make it easy for patients.
Yep. And again, having freestanding, imaging as well as mobile imaging for patient convenience. So we really strive to make it easy on the patient to get to the clinic and get imaging completed.
And so I had a couple of questions. So do you guys get a lot of questions about like doing an open MRI versus like what we have, which I believe we have wide bore MRIs, um, like for patients that are claustrophobic, and kind of what's the difference between them. Because I had heard, I think I might have, I don't know who I asked this question to before, but I'd heard that like the open MRIs, the images aren't as clear. Can you talk a little bit about kind of why our company chooses to go with one versus the other?
Well, I mean, yeah, unfortunately, I mean, an open MRI is a nice option for patients that are very claustrophobic. But in reality, for cancer-related things, it's, can be very difficult to rely on them for, I mentioned a brain tumor, an open MRI is just not going to give you the same level of detail that you need. For certain other indications of an MRI, maybe an open MRI is a reasonable substitute, on the maybe on the orthopedic front or other things like that. But for a lot of these, unfortunately for these cancer related scans, a lot of times you really need a fixed unit or a closed, unit to really do the appropriate sequencing, do the appropriate protocols with the appropriate resolution. And most open MRIs are just not going to have that.
Yeah, and
So
Gotcha.
I think,
we prescribe, at least I prescribe a lot of medication for patients to help make sure they can relax for the MRI if they need be. Those who are claustrophobic and things like that. So there are a lot of ways we can usually get most patients through an a regular MRI. And yeah, I typically, if a patient can only get an open MRI in a lot of ways, I'll just tell them don't even waste their time, because for what I need, at least I can only speak to the radiation side. Usually not super helpful.
mhm. I agree with that. I think there's certain times where we're not really looking at a particular tumor or, I definitely agree with you on the MRI of the brain, not to go through an open MRI for that. But there are times where I've ordered it in the setting of like an abdominal scan or maybe even a lower spine, um, MRI. But outside of that, I think the quality of the imaging. And now, I mean, I tell patients too, the newer MRIs now are actually wider bore and a little bit more comfortable. And we can always give anti-anxiety medication to help with the process of getting the MRI done. So we try to make it as easy as possible for patients, but you don't want to sacrifice the quality of the image and waste money and then have to do something again just to make it comfortable. So we try to do whatever we can to make it comfortable for patients.
And then currently we have, like you guys said, we have two, or we have one mobile MRI unit, but we're getting a fixed MRI in June, I think. End of June, I think the imaging center right there in the parking lot where Rick is opening. So
Mhm.
is there a is there a big difference, or is it just, between the imaging between a fixed and mobile, like the quality, or is it pretty much
It's just scanner specific. So,
Mhm.
the newer mobile units are going to be almost as good as the newer, fixed units. I think the fixed units, the throughput might be a little faster. So you might be able to scan somebody with the same protocol slightly faster. There might be a few different protocols available, or sometimes, if the techs need more room to do certain sequences or certain like harness devices or other things that sometimes get added on to the MRIs. Sometimes a fixed unit, you might have a little more room to do that. But it really just depends on, what generation of machine. An MRI from 10 years ago is not going to be able to do a lot of the stuff that a new MRI does, whether that new MRI is fixed or whether that new MRI is mobile. So I think it's more of a, where's the technology, what level of MRI is it versus necessarily a fixed versus mobile MRI.
And then I think it's just worth mentioning across all of our sites, we have nine, including the three mobile, we have nine imaging units, which is, I would say, pretty impressive for the size of our company. And, I think it speaks a lot to patient care and the convenience and kind of our mission of keeping things in the neighborhood and
Yeah.
patients not having to travel far. So,
And I think scheduling wise, I mean, we've been pretty uh, quick at getting patients CT imaging, PET CT imaging. Sometimes, within the week they're in there getting imaging, or within a few days. So that's quick in comparison to some of the hospital systems around the area. I think, MRI imaging, because the MRIs take longer to do, sometimes scheduling can be a little bit more backed up because of that. But we're kind of striving to get to the point with the new fixed MRI that we're not having weeks delay getting people in for an MRI, that hopefully will be in line with our CT imaging and PET CT capabilities of doing it within about a week or so.
Cool. Good stuff. We'll have to have Leah on when that opens, and maybe we can do like a video tour on site.
Yeah.
We can do an on-site recording.
Check out the new devices.
Absolutely.
Thanks again, guys, for joining us on another episode of the Rick and Danny Show. Rick, thanks for all your explanation about our imaging capabilities, and looking forward to our new center opening up with our new fixed units.
You did just as much contributing, but I appreciate it, and appreciate all the listeners out there for their support.
He's making up for hating on your golf game at the beginning there.
That's true. Thanks, guys.